Good afternoon, everybody, and thank you for joining us. Welcome to this webinar. We are really pleased that you can be here today with us. The webinar is on multidisciplinary management of low-grade gliomas in light of the new introduction of mutant IDH inhibitors. My name is Isabel Germano. I am the chair of the AANS-CNS section on tumors. Our organization was founded 40 years ago exactly, and through the hard work of its chair people, as well as their executive committee members, the organization has risen to become the largest global association of neurological surgeons and advanced practice providers that are devoted to care for patients with brain and spine tumors. You can see in this picture the previous presidents, and you can also see a picture of our current executive committee with their members, and I am particularly grateful to each of them that I have chose and who agreed to serve the section for their very hard work and dedication. And today, in particular, I'm very thankful to Eva, Mark, and Randy, who are our panelists and moderators. The AANS-CNS section on tumor mission is to provide a platform for education, research, and advocacy for individuals affected by these conditions. We have approximately 300 members worldwide, and we're actively coordinating activities and programs that are related to brain tumors and spine tumors, including trial, research, and education. And today is a prime example of the effort that are very dear to our hearts, and that is multidisciplinary collaboration. That said, let me introduce and pass the baton to our co-moderator, Dr. Eva Galanis. It would take probably a full lecture to properly introduce her, but let me just tell you that she is a professor of oncology and the Sandra J. Schultz Professor of Novel Therapeutics at the Mayo Clinic. Additionally, she serves as the group chair of the Cancer Cooperative Alliance for Clinical Trials in Oncology, and is the president-elect for the Society of Neuro-oncology, also known as SNO. Within the executive committee of the section on tumor, she serves with Dr. Mark Gilbert as the co-chair for medical oncology. Eva, the floor is yours.
Thank you very much, Isabel. A true pleasure and honor joining all of you today. I want to welcome my co-moderator, Dr. Mark Gilbert, who is a senior investigator and leads the neuro-oncology branch of the NCI. And we have truly assembled today an exceptional panel, including Dr. Patrick Wen from Dana-Farber Cancer Institute, Dr. Christine Redmond from Johns Hopkins, Dr. Randy Jensen from the University of Utah. And following their presentations, we are going to expand our panel to include 3 more discussants. 2 European colleagues, Professors Van den Bend from Netherlands and Simon from Germany. Thank you very much for staying up late to join our company, and also Dr. Germano. And at this point, I would like to turn the floor to Dr. Gilbert, who is going to describe the structure of the webinar today.
Great. Well, thank you so much, Eva and Isabel. It is a great honor and pleasure to be part of this webinar. Isabel, you may want to switch the display settings since we're seeing the presenter mode. And let me, while you do that, describe to everybody the sort of the format. So it's an interesting format. We are going to be talking about low-grade glioma, and we've asked our Dr. Wen, Dr. Redmond, and Dr. Jensen to each give a 5-minute overview of the management of low-grade glioma, sort of state of the art from a neuro-oncology, medical oncology perspective, radiation oncology, and neurosurgical perspective. And then they're going to turn around and, in that same order, talk about their thoughts about the implication of having an IDH inhibitor as a treatment agent, in particular vorasidenib, in light of the recent pivotal publication in the New England Journal of Medicine. So I'm going to, and that will be followed by a panel discussion with all of the colleagues, open to questions and hopefully a lot of interaction and dialogue. And so that we're all prepared when we start to have agents like vorasidenib in our armamentarium. So without further ado, let me ask Dr. Wen to take the stage and talk about his thoughts about the current state of the art.
Thanks so much, Mark. Thank you, Isabel and Eva and all the other organizers. So I was asked to talk briefly about medical treatment for low-grade glioma next. There's no cure for these patients, but the first step is maximum surgical resection. And if a gross total resection can be achieved, and if the patient is under the age of 40, these are considered low-risk patients, and we can usually observe them. But for patients with subtotal resection or above the age of 40, they're considered at higher risk for recurrence, and they're usually recommended to have treatment with radiotherapy and chemotherapy, usually PCV for oligodendrogliomas and temozolomide for astrocytomas. For grade 3 gliomas, regardless of the extent of resection, after recovery from surgery, the recommendation is usually radiation and chemotherapy. And again, PCV usually for oligodendrogliomas and temozolomide for astrocytomas, although the alternate agents are sometimes used. Next. These chemotherapy agents were based on several phase 3 trials that have been important in our field. For grade 2 gliomas, RTOG 9802 demonstrated that the addition of PCV prolonged survival when added to radiation therapy. And in the panel on the left, the top panel shows oligodendroglioma showing the greatest benefit. The middle panel showing astrocytomas that shows significant, although lesser benefit. The RTOG and EORTC have also shown that the addition of PCV to radiation therapy significantly prolongs survival in grade 3 oligodendrogliomas. And then in the panel on the right, Martin van den Bent led the CATON trial demonstrating the benefit of temozolomide in grade 3 astrocytomas. In the lower panel, the first interim analysis demonstrated conclusively that a year of adjuvant temozolomide prolonged survival. And then in the upper panel, the second interim analysis examined the value of concomitant temozolomide during radiation therapy. And although the curves split, it did not reach statistical significance. Next. All these studies show that radiation and chemotherapy significantly prolong survival. For grade 3 oligodendrogliomas, the median survival is 14 years. And at 20 years, 30% of patients remain progression-free. So these patients can do really well. But one of the consequences of patients living a long time after radiation therapy is that they experience the delayed sequelae of the radiotherapy. And the MRI scan at the bottom shows a patient of mine that I've looked after for the past 20 years with bifrontal astrocytoma. She has never recurred, but for the past 3 years has required 24-hour care. And although our treatments with radiochemotherapy is effective, we need other treatments that have less toxicity. Next. There's been a lot of interest in IDH inhibitors, and this culminated in the Indigo trial that was reported last year. This was a phase 3 trial evaluating vorasidenib, a brain-penetrant IDH1 and 2 inhibitor in grade 2 IDH mutated gliomas. These patients had only prior surgery between 1 to 5 years previously. They all had to have measurable disease, and 80% of them had more than 2 centimeters of tumor. So they would be considered at high risk, and they were felt not to be in need of immediate radiation and chemotherapy. Patients were randomized to vorasidenib or placebo, and the primary endpoint was progression-free survival by blind independent radiology committee, and a key secondary endpoint was time to next tumor intervention. And as you can see here, the primary endpoint shows significant increase in progression-free survival with vorasidenib, with a hazard ratio of 0.39 and a significant p-value. And so vorasidenib represents a potential new treatment for patients with these tumors, and we'll know by the end of August whether it receives FDA approval. Thank you.
Dr. Redmond? Dr. Redmond, we can't hear you.
Are you hearing me now?
Yes.
Thank you all for the opportunity to present today. My disclosures are listed on the next slide, and then the first content slide is the one after that. Radiation technology has improved dramatically over the last decade or two, with tremendous advancements, both in imaging technology that allow us to better visualize the tumor, as well as manners to deliver radiation in a very precise manner and confirm that we are delivering it in the direction that we anticipate, allowing us to make our margins smaller and treat smaller areas of the brain and other parts of the body. Nonetheless, the data that really drives decision-making for radiation therapy in the context of low-grade gliomas is a couple decades old. And so there are two kind of critical studies that are typically referenced. So the first being the so-called non-believers study, in which patients were randomized to either 54 gray of radiation or observation. And what they found was a significant benefit in progression-free survival, but not overall survival with radiation therapy. Next slide. What was also found is that the radiation did improve the seizure control at 1 year, so it plays an important role in patients with uncontrolled seizures. And importantly, we previously were concerned that radiation may increase the likelihood of transformation to higher grade disease, and indeed that does not appear to be the case. So what this study really answered in the end is that in patients who are asymptomatic, it is okay to observe them in order to delay the sequelae of brain radiation. The second study that we regularly talk about is the so-called believer study. And so in this study, patients were randomized to either 45 gray of radiation or 59.4 gray of radiation. And what they found was no difference in response between these two dose regimens. In current practice, we typically will treat patients to between 50 and 54 gray, which is really because that dose is deemed safe. In making decisions for patients, who are we going to observe, who are we going to treat, there are two risk stratification schemas that are taken into account. The first was mentioned by Dr. Wen. Essentially, patients are deemed low risk if they are less than 40 years old, and the surgeon defines them as having a gross total resection. And then anything else is deemed high risk. And according to the stratification system, high-risk patients warrant radiation therapy or chemoradiation therapy. The second stratification system is this EORTC system, in which patients with three or more of 5 risk factors are considered high risk. So size of at least 6 centimeters, age of at least 40, tumor crossing midline, astrocytoma, and then neurologic symptoms prior to surgery. Next slide. As Dr. Wen explained, we have a large study that was, again, initially run at that same timeline a couple of decades ago, where patients with high-risk low-grade gliomas were randomized to either radiation alone, 54 gray, or radiation followed by PCV chemotherapy. And what they found was a dramatic benefit in terms of overall survival in patients who received chemotherapy in addition to the radiation. And this held true for both oligodendrogliomas and astrocytomas, and there was no benefit of PCV in patients with IDH wild type tumors. So in the end, what this is answering is not necessarily the timeline of radiation, but rather we know that whenever we're going to pull the trigger and move forward with radiation, they should receive chemotherapy as well. Thank you very much.
Dr. Jentz?
Well, thank you for allowing me to be part of this great panel today. Next slide. So it's very clear from the literature that the extent of resection in low-grade patients really does matter. And there are studies that would suggest that this is especially true in the case of those IDH1 mutant low-grade tumors, where even small residual volumes can predict a worse outcome. Next. And that's been backed up by other studies where the molecular diagnosis of an IDH1 mutant tumor is important to consider in this extent of resection. Next slide. But the problem is that we have this Goldilocks phenomena where we want to resect as much as possible, but giving somebody a new deficit post-operatively makes it less likely that they're going to undergo adjuvant therapy, they're going to have a lower quality of life, and a shorter overall survival. So we need to go to great lengths to try to prevent that. Now, Now, to do that, our goals really are to perform a maximal resection according to the functional boundaries that can be determined with a number of preoperative modalities and intraoperative cortical mapping. And there's strong evidence to suggest that modalities such as awake craniotomy with cortical speech mapping can result in a higher resection and a lower rate of postoperative complications. Adjuvants like neuronavigation are now extremely important. The use of intraoperative MRI has proved very valuable in low-grade gliomas. Unfortunately, our 5-ALA has fluorescence-guided surgery has not been so good for the low grades, but there's still groups who are trying to make emerging studies there. But we go to great lengths using everything that we can. Functional MRI, next slide, magnetic encephalography with source imaging, using diffusion tensor imaging to look for those white matter tracks, perfusion MRI, navigated transcortical stimulation, spending time with the neuropsychologist, water testing if necessary, and then coupling all of those preoperative modalities together to do what we can to get the maximal safe resection. Next slide. Let's see. And these are just some examples of those modalities that we can use to try to prevent injury to the cortex, give a patient new deficit. Thank you.
Great. Thank you all. Now we're going to go back and ask each of our speakers to talk about their thoughts about the impact of having an IDH inhibitor drug to use in the treatment of low-grade glioma. So Dr. Wen?
Thank you, Mark. Next slide. So I showed earlier that vorasidenib significantly prolongs progression-free survival Next. But I think as importantly, if not more importantly, it delays the time to next tumor intervention. And so one of the major roles for this drug may be to be used to keep the tumor stable and delay the onset of radiochemotherapy. And this is a very easy drug for patients. Most of them don't know that they're taking a drug, and so their quality of life is very good. Next. So who should use vorasidenib? Next. Should it be those patients who fulfill only the indigo criteria, grade 2 gliomas, who've only had surgery 1 to 5 years previously? The 1 to 5 years is somewhat arbitrary, and so certainly next, there's no reason why you can't start the drug immediately after surgery. And the trial was chosen to be focused on grade 2 gliomas because the phase 1 studies had shown that they had the best outcome. But potentially there might be a role also for grade 3 gliomas. In the past, grade 3 gliomas, which included wild-type tumors, were thought to be much worse than grade 2. But if you only look at IDH-mutated grade 2 and grade 3 gliomas, the outcomes are much less different than we would imagine. There are some studies, such as the MD Anderson study, showing no difference in outcome between IDH-mutated grade 2 and grade 3 gliomas. And other studies have shown a slightly worse outcome with astrocytomas that are grade 3 compared to grade 2, but the difference is not statistically significant. Next. And maybe you could fill the whole screen. So Martin van den Bent, who can comment on this, has led an effort to look at outcomes of grade 2 and 3 gliomas, as well as outcomes from the IDH inhibitor trials. And these studies show that grade 3 gliomas also benefit from IDH inhibitors, although generally those that are non-enhancing. Can you scroll through all the other, just go all the way to the bottom. So should we use IDH inhibitors for grade 3 gliomas also? All the phase 1 trials were in recurrent tumors, which are generally harder to treat. And so potentially the outcomes may be even better if we're using first line. There's a perception that oligodendrogliomas may do better than astrocytomas. But the evidence is that IDH inhibitors should work as well for astrocytomas. There are some complexity if there are other pathways that are activated, such as CDKN2A loss. Does that predict the lack of benefit from these inhibitors? These are things that we will have to learn over time. And then the phase 1 study showed activity in recurrent grade 2 and 3 tumors, but mainly in non-enhancing tumors. So there may be a role there. Next. And then in addition to patients who've only had surgery, there's potential role for vorasidenib in other settings. Some patients will need to have radiochemotherapy from the onset, and there is a trial that is planned in Alliance, hopefully, adding vorasidenib to radiochemotherapy in grade 2 and 3 astrocytomas in first line. There are planned trials to look at the addition of vorasidenib for grade 4 astrocytomas, for which there are very few novel treatment options right now. And there are also proposed trials looking at starting vorasidenib after completion of radiochemotherapy. But as the phase 1 trial showed, there is also activity of these drugs in recurrent tumors, and whether vorasidenib should be used alone or in combination with chemotherapy or immunotherapy or other agents remains to be determined. But in addition to the strict indigo criteria, there is really a lot of potential roles for vorasidenib, and this is something that we will have to study going forwards. And hopefully in August, this drug will get approved and we will have a new treatment for our patients since temozolomide was introduced in the 1990s. Thank you.
Great. Thank you, Dr. Wen. Dr. Redman?
There are a lot of uncertainties in the management of low-grade gliomas at this point in time, and certainly the integration of IDH inhibitors into our practices increases. Well, it's an excellent option. It also increases some of our uncertainties. The data that I discussed in the previous section shows us that with certainty that when we treat patients with radiation, we should be adding chemotherapy. But in terms of when to pull that trigger and move forward with radiation therapy, we don't really know. Ultimately, our goal is to maximize patients' overall survival while minimizing their toxicity. And as Dr. Wen mentioned previously, a significant concern that we have with brain radiation is the possibility of neurocognitive toxicity. This is an example of an older study in which children with medulloblastoma were treated with either 25 gray or 35 gray of cranial spinal radiation. And you'll note that this is lower than the doses we use in low-grade gliomas. And what they found was significantly poorer performance on this test of full-scale IQ in patients that received the higher doses of radiation. So certainly giving us a reason for caution. Next slide. Our modern radiation techniques, we are increasingly understanding that certain areas of the brain likely contribute to cognitive toxicity more than others. An area that has received a lot of attention over the last decade is the hippocampus. This is an example study that was done in patients with brain metastases, where they were treated with either whole brain radiation or hippocampal sparing whole brain radiation. And what you see is that the risk of cognitive failure is significantly lower in patients who underwent hippocampal avoidance. Next slide. Interestingly, a lot of these sparing studies have the constraints that have been utilized are really what is possible as opposed to what is meaningful. This is a study that was done by Martin Ma, who's a former medical student at Hopkins, that allows us to better understand the radiation dose tolerance of the hippocampus and allows us to tailor our dose constraints to individual clinical scenarios. Next slide. In terms of other ways to help spare the parts of the brain, protons are increasingly receiving attention. The beauty of protons that you see in this image here is that it helps to reduce the low dose back to distant areas of the brain. But they need to be applied with caution in that there's more heterogeneity of the dose, more hot spots and cold spots, and so possibility of potentially increased risk of necrosis with proton therapy. So to conclude, radiation is beneficial in patients with high-risk, low-grade gliomas, and we have compelling data to support the use of chemotherapy with radiation, but it does not answer the question regarding the optimal timeline. Ultimately, we really need prospective data to better explore the optimal sequencing of IDH inhibitors and chemoradiation therapy. Certainly, as Dr. Wen mentioned, they are an excellent tool to help us delay radiation, but we do need more information to see if this would impact overall survival because we simply don't know at this point in time. Thank you very much.
Thank you, Dr. Edmond. Dr. Jensen?
Yes. So this topic has been one of much discussion in our tumor board, and our neuro-oncologists have repeatedly reminded me that the surgical studies that we've talked about, the gross total resection is still standard of care, as that's been proven to improve both overall survival and progression-free survival. Where the Indigo study, the data there really was the progression-free survival and then the time to the next required treatment. Next slide. So we know from that study that diffuse gliomas with IDH1 mutations are not curable with current therapies and infiltrate the brain in the absence of treatment. Verosimab is an oral inhibitor of the mutant IDH1 enzymes with proven brain penetrance. And this treatment significantly improved progression-free survival and time to the next treatment. And it has a manageable safety profile. Next slide. But I think maybe one more click, Isabel, if you don't want. Yeah. So I think that our current state is that if possible, a gross total resection in non-eloquent, whatever that means, that's sort of in the eye of the beholder, but when possible, we should try to get a gross total resection. If it's necessary because of language, motor, anything in the operating room that we encounter that makes a complete resection not feasible, the IDH1 inhibitor might be used to close that gap that we see in the studies that I mentioned previously of the small residual in the IDH1 mutants. This may be a way to bridge that gap. My screen, oh, let me move that. My screen, there's something blocking there. What we don't know is what the long-term effect on overall survival is with the IDH1 mutant inhibitors. We don't know the long-term durability, and we don't know about the large tumor that maybe only a biopsy is performed. Next slide. But what we hope that it may be possible at some point where when we have a patient with a diffuse tumor in a very tricky area, somewhere where we think that there's a high chance for morbidity or mortality with the surgery, that we might be able to perform a safe biopsy and be able to use this IDH1 inhibitor as a first option, first line without, or even maybe first line without a biopsy, if we ever get comfortable with that. Certainly it could be combined with our current status with chemoradiation and might add to that, or with our immune modulators where there's been some glimmer of hope that some of those might be useful in low-grade gliomas. Next slide. I think that was it.
Okay. Thank you all very much for these presentations and very thoughtful discussion. Now, if I would like to ask our panelists to all turn their cameras on and our participants to send their questions in the chat. We already have one question, and I will paraphrase it so we can discuss it in a broader context. We are discussing about inhibitors of IDH, and the same mutations, IDH1 and 2, are seen also in other tumor types, such as AML, cholangiocarcinoma. And indeed, there are inhibitors that they are FDA approved for these indications, while we do not have such approvals for gliomas yet. Nevertheless, there are patients, especially in the context of recurrent IDH mutant glioma, who may be treated with an IDH inhibitor approved for a different indication. And such an example is the Tibsovo or ivosidenib, which is not identical to vorasidenib. Ivosidenib is an IDH1 inhibitor. Vorasidenib is an IDH1 and 2 inhibitor and has better brain penetration. So realizing that we do not exactly have a direct answer to that, I would like our panelists, and perhaps I will start with Dr. Van den Bend, to comment on the issue of the resistance to IDH inhibitors. What do we know about mechanisms of resistance? And if we have a patient with an IDH1 mutation who has failed or progressed on IDH1 inhibitor, based on the available evidence, which I realize is imperfect, is there support to consider treating these patients with an inhibitor such as vorasidenib?
Yeah, that's the $1 million question, I think. And perhaps it would be better stated if you say we don't have any evidence. I don't think we know why patients are responding and why patients stop to respond. I think that's one of the key questions that we are, as a field, we have to answer in the coming years, is to get tissue samples from the patient that stop to respond or that fail to respond and see how they are different from the patient that are responding. So as of today, we don't know, let alone that we know what happens if you treat a patient with one IDH inhibitor fails and whether you can switch him to another IDH inhibitor. We just don't know. There are no data on that. What I would think, though, is that the choice for vorasidenib to take that drug forward in the Indigo trial was made on a very elaborate comparison between ivosidenib and vorasidenib. The brain penetration of vorasidenib is better than ivosidenib. The reduction of 2-HG was superior in vorasidenib as compared to ivosidenib. So I would think that the choice for vorasidenib was made on very rational grounds. So if anybody fails to vorasidenib, I would think that the idea that he might respond to ivosidenib is really speculative. And it would really depend on the clinical situation of that particular patient, whether that would be something that you can try. What we know is that radiation therapy and chemotherapy is very effective. So in any case of a patient that really needs further treatment, the safe choice would be to go for radiation therapy and chemotherapy. If you have, however, time, if there is a small lesion that's not impeding the function of the patient, one could try, but there are really no data.
Thank you very much, Martin. There is another question in the chat regarding the use of vincristine. So vincristine is part of the PCV regimen, which we heard in RTOG 9802 has been shown to prolong progression-free survival and overall survival. And PCV, it is a toxic regimen. The question is about peripheral neuropathy, and yes, we do see that. So close monitoring is needed. And of the 3 drugs of this regimen, procarbazine, CCNU, and vincristine is probably the less useful. So we tend to drop it off with the first sign of peripheral neuropathy.
Eva, can I ask a quick question to Dr. Simon? Dr. Simon is here representing the European Association of Neurological Surgeons. Thank you for the late evening presence here. And Matthias, in your practice, so we heard from Dr. Wang, who told us numerous times that in our country, the drug is not FDA approved yet, and we're hoping to have it FDA approved in the summer, but instead in Europe, this has been approved and used for quite a while. So my question to you is, in your practice as a neurosurgeon, have you noticed any difference in your approach to low glioma patients?
Well, to the best of my knowledge, vorasidenib is not yet approved in Europe. I think the approval process is ongoing. Maybe Martin knows better than I do, being a neuro-oncologist. I think we're all eagerly awaiting it, and then I guess we'll see. Actually, if you don't mind me asking one question to all the panelists, will I have to change my approach to recurrence, to repeat surgery for a low-grade glioma, if at some point vorasidenib becomes available through the usual reimbursement agencies?
This is a very good question. Dr. Wen, would you like to offer your thoughts?
Well, sorry, whether you would need to do surgery for recurrent tumors?
Will I have to change my attitude towards doing repeat surgery for a recurrent low-grade glioma if vorasidenib becomes widely available?
I guess if it becomes widely available, a lot of these patients would have seen vorasidenib. And so when they recur, they're probably resistant to vorasidenib, and so they need other treatments. But for the patients who have not seen an IDH inhibitor, if you see just non-enhancing progression, you could argue that you could try the vorasidenib first before you do more surgery. because that's the group where it's most likely to have activity. And from the phase 1 trials, we have patients now 8 years or so that are still on trial. So for small groups of patients, it really can be quite helpful.
I would echo that. Of course, it's difficult to know how well this will be covered because the approval will be for a different indication. But the expanded phase 1 trial data indicated a median progression-free survival in the range of 20 months for patients with non-enhancing tumors. Enhancing tumors is much shorter. So depending again, where is the location, what could be the impact of the surgical intervention, it might make sense to consider an IDH inhibitor such as vorasidenib, provided that the insurance would cover for that.
Can I state the contrarian view? And I would suggest that in recurrence, there is not an infrequent transformation from grade 2 to grade 3. And we don't have any evidence yet that vorasidenib works in grade 3 or transforming low-grade glioma. And in that case, there may be some hesitancy. So if you do a resection, you'll have the opportunity to take a look and see if there are molecular changes that would be concerning, and sort of steer you away from that. So having that information, again, it's all predicated on location and safety, et cetera, but I would suggest to have a lower threshold.
I think that going from the paradigm of what was described in these beautiful presentations, for us neurosurgeons, the window of opportunity to perhaps use the vorasidenib is when, after we do a gross total resection, there could not be a gross total resection for the reasons that Dr. Jensen explained, that the piece of tumor is in eloquent area. And that patient is considered high risk because it's above 40. So rather than delivering the chemotherapy with XRT, maybe that patient is a good candidate to receive that vorasidenib right away, rather than waiting. Alternatively, I could also see when a gross total resection was accomplished and then there is a small recurrence, if the patient does not agree to undergo surgery, and there are some patients that say, thank you, one surgery was enough. So maybe that is also another window of opportunity for the vorasidenib before the XRT. Matthias and Randy, any other thoughts from the surgical standpoint?
Well, perhaps from a medical oncology standpoint, I think there's a big difference between patients that have undergone radiation therapy and chemotherapy versus those that have only undergone surgery. If the GLASS consortium, that magnificent effort to look at paired samples from patients having undergone more than one resection and look at the differences at the molecular level, show that there is relatively little change if a patient has not undergone any subsequent treatment after that first surgery, which is usually different after radiation therapy and chemotherapy. So the lesson learned from the Indigo trial is that those patients that have not undergone radiation therapy and chemotherapy have a fair chance of responding to those are IDH inhibitors, which is completely different from those that have undergone radiation therapy and chemotherapy. They have a lot of other molecular differences, and they may actually be not depending anymore on the IDH mutation for their tumor growth. So I think this question is really you have a patient that have undergone only a surgery, then develops a recurrence. What do? You send for another resection, you go for the ivosidenib. That's an unresolved question as far as I'm concerned. And it really, from a neurology point of view, it would depend on how safe is that surgery, how easily can that lesion be taken out, what's the risk for the patient for new deficits.
So Martin, I would like to qualify. So the idea of tumor recurrence, if it's only been a surgical procedure and some patients get years from that, but is that really recurrent or is it just the regrowth, right? So when I think of recurrence, and maybe this is being nitpicking, it's after additional therapy, radiation, chemotherapy, and in that context, as you pointed out, there are often significant molecular changes. So that was the situation that I was referring to as far as the potential need and benefit from another surgical procedure before proceeding. But I agree completely. And the Indigo trial, many of the patients were under observation and then showed tumor growth. So that's the exact circumstance, right? So agree.
I want to make a point about recurrent tumors. So all the phase 1 trials were done in recurrent disease. And many of those patients had prior radiation and chemotherapy. And so it isn't that there's no activity after they've had radiation and chemotherapy. And if you look at the data, even though the outcomes are best with grade 2 tumors, even grade 3 tumors, with some trials like safusidenib or DS1001, a lot of those patients had grade 3 tumors. So, grade 3 tumors and tumors after radiation chemotherapy can respond if they predominantly are non-enhancing. The ones that are enhancing presumably have transformed and have other pathways activated and don't respond as well. But it's not as clear-cut as this is only a drug for grade 2 tumors that have not been treated with anything.
Very good. Dr. Simon, any additional thoughts before we go back to the chat?
Well, just let me give you a number. If you look at the surgical results in terms of surgery for recurrent low-grade glioma disease, I know these patients here are very much selected, but you can find figures like 90% 5-year overall survival in these series, which seems to me a lot better than the figures that we found in the Indigo trial. The way I understand the Indigo trial, this is somewhere in between treating a recurrence and treating incompletely resected tumors. And then the survival figures or the progression-free survival figures shown are not all that impressive. That may be due to selection bias, but then is this enough, again, for me to justify to change my attitude? I think in the neurosurgical community, when I look at Isabel and Randy, we probably all go for a safe gross total resection in a case with something that we call a recurrent low-grade glioma, right? And we would probably reserve an EDH inhibitor for cases where we can't do that, or as Isabel pointed out, if patients want it that way. Is this something that the neurosurgeons in the panel would agree upon?
I think I would agree, and I'm being biased because I've been pushed that way from my neuro-oncologists who are telling me, hey, maybe we're not solid enough on the data yet. We know that the resection, when possible, works, and we get this molecular data back. So we've certainly done that. Certainly in the case when there's been a new enhancement or anything unusual about the characteristics of the recurrence, we've gone down that road. But I agree with Isabel. There's plenty of patients who say, been there, done that. I've had my surgery and I'm not going back to that again. And I think this is a great something to have in our back pocket.
Yeah.
So I would like to, sorry, Eva, I would like to thank Mark for making the difference between regrowth and progression, very important one. So for a patient where I performed a gross total resection, and after a period of time, there is a new non-enhancing nodule that is a regrowth. And to me, that patient is the same as when the patient first presented. So according to what Randy's data, the data that Randy shared with us today, a gross total resection is still the best possible treatment for that patient who regrew, if I, as a neurosurgeon, feel that I can give that resection without inducing a deficit. So a regrowth, to me, is to be treated as a patient that has never been operated on, provided that the patient wants to have the surgery. So I would offer surgery for that particular patient. But then again, if the patient doesn't want to, rather than having the adjuvant treatment, then maybe we could turn toward the mutant IDH inhibitor.
Okay, all of these are excellent points, and I think we all agree that the approval of these inhibitors, if it happens, will give us much greater flexibility and the opportunity to individualize treatment, perhaps intervene with a medical intervention when the surgery can result in neurologic deficit, perhaps limit the modify the extent of surgery because there is something else to offer if the risk is too high, and also more flexibility for the patients. And I would totally agree that in the context of true recurrence, enhancing versus non-enhancing based on the available data would really help us think how to best utilize those agents. And of course, we're talking about all these treatments, both in the US and Europe. And then there are parts of the world where there is the luxury of having these treatments available is not there. For example, our colleague here from Afghanistan, who is talking about management of these tumors in the context of perhaps other technology, less modern technology for radiation therapy and some older chemotherapies. What the panel would have to offer. I think there perhaps the role of surgery is even more important.
Well, maybe we can start with Kristen and hear what would be your thoughts with limited resources. What would be the radiation that you would perhaps recommend for patients in this situation?
So obviously the radiation that we can deliver is entirely dependent on the technology that we have. And if there simply is no linear accelerator and not even a cobalt machine, then our hands are kind of tied. We can't radiate something without a device that allows us to do it. Certainly there are, even with things like cobalt machines, there's 3D conformal techniques that can be utilized to deliver the radiation. And I agree with the comments that were just made that in patients who aren't able to be radiated, then the surgical resection is extremely important in the absence of the ability to give adjuvant therapy.
And then I would add to that one of the oldest drugs, it's a 30-plus-year-old drug, the nitrosoureas, do have activity. Indeed, the RTOG-9802 used a regimen based on this much older drug. Hopefully this is available in Afghanistan, and hopefully that's something that you can use following radiation therapy. I think we are getting close to the end. However, I think we do have time for one more question. And I would like to ask perhaps our neurosurgical colleagues or Dr. Wen or Dr. Van de Ven to comment on use of gliadal wafers for low-grade glioma. I mean, obviously in the US, this is not FDA approved for low-grade glioma indication. Here we have a colleague from Colombia who is asking this question.
If you want me to answer to that question, I have a very strong opinion against using these wafers because I just don't understand how they can work. I mean, what you end up doing is you're placing something against a surface. You have all these problems with diffusion, and then how is it distributed in your area of interest, the infiltration zone? So I have never used the wafers, and I can't foresee a future where I will do so.
Okay, I think Dr. Simon summarized the very low enthusiasm for
Sorry.
this approach.
Precludes from being on clinical trials too. So that for us, that if somebody's used those, then we can't put them on a clinical trial down the road, and we don't want to do anything that's gonna hamper that. So.
So is there consensus on that one? We're all against it, and there is no evidence supporting its use for low-grade gliomas. Very good, and we are very close to the end of time. I want to thank very much our panelists for really very thoughtful and comprehensive discussion, to acknowledge my co-moderator, Dr. Gilbert, and of course, Isabel, who once again brought us all together. Isabel, I'm turning it to you for the last words.
Well, thank you so much for your time and dedication, enthusiasm, and especially thank you for taking care of patients that are really in need for answers, and families. And it's really nice to know that across the globe, we're all connected, and this is our mission, and we want this to continue over the years. So thank you all, and more to this interdisciplinary as we move along the years.
Thank you.
Thank you.